Thanks, Ken, for the introduction. Just a little bit more to establish a bit of an ethos here before we get going is prior to coming back, I'm originally from Boardman, Ohio. Went to New York City for a couple years of residency and practiced there as an infectious disease specialist in Brooklyn, New York for more than 3 years after all my residencies. Real underserved place. Had to do more things like a physician than a pharmacist because that's how I was trained for one. That's how I practiced afterwards. So from diagnostics all the way through discharge. And for some of you that don't have the MD or DO, there's always a little bit more of a chip on your shoulder to get things right, especially when the responsibility falls on you. So that always forced me to be sort of, accountable with everything I did. So one of the things I will also say before I get started is what I would consider the most frustrating thing in the healthcare field, and that's really when people become comfortable. They spent all these years getting to the upper levels, to practicing on actual patients, done with school, years and years of spending money for this and that, and then they get there and they get comfortable. They give clindamycin in a situation where it might not be needed just because they saw somebody else do it 10 times in that scenario, so they assume it's okay. They give doxycycline for this reason, they give ciproflagyl for that reason, and they do it all because they've seen somebody else do it before. You ask them why they're doing it, they're saying, well, ciproflagyl's for colitis, but they don't really know why they were using it for colitis or why the surgeons who used it a ton 20 years ago for colitis we're all using it then, but it might not be the best choice now. So what I tell everyone before I speak to them at all is question everything. Question what I say. Don't become comfortable in what you're doing, because just because you saw somebody else do it 100 times doesn't make it right. And that's particular to infectious disease. So many of the studies that are done in infectious disease, you can never really quantify a person's immune system. It's like a lot of surgical studies. It's very difficult to quantify the skill of the surgeon to know how appropriate a certain procedure is. Same thing applies for infectious disease. Always look at a skeptical eye with a lot of the studies because it's tough to quantify the human immune system. Yes, we could say it's better than placebo, but is it better than nothing? Hard to say with a lot of scenarios. So again, always, anybody could shout out anytime they want during this, ask questions, stop me while we're going. But the point is, question what I say, question what everyone says, because a lot of the time, it becomes a monkey see, monkey do environment at the very top levels. People are doing the things just because they saw them done before and don't know why they're even doing it. Don't even know what antibiotics are covering what organisms. So question everything. Those of you who have seen me at the boot camp before, talked about a lot of these issues. They're updated. We're going to go through them again for the first talk that I'm giving. Then afterwards, we're going to do a non-ID talk. So these are all the topics I'm going to hit here. Antibiotics for upper respiratory tract infections. They're typically viral. Acute bronchitis. So many people want to give antibiotics for acute bronchitis. There's never been evidence that this works. The reason I always bring it up is for those of you that are going to see a patient, diagnose them with acute bronchitis, send them home on an antibiotic, you run the risk of really getting yourself in trouble. You send them home on Levaquin. You diagnosed acute bronchitis. They have an adverse reaction to the drug. Well, you could be liable for that. And you hate to practice defensive medicine, but then what's the counterpoint? What if you don't give them anything? Well, the CDC has your back on that. They're saying, don't give antibiotics in acute bronchitis. And Infectious Disease Society of America has your back on that. So the law's on your side to give nothing in acute bronchitis. And I know on the ground level, it's always a lot more difficult when you have a patient who's there. They've been given 20 Z-Paks for their last 20 colds over the last 20 years, and they want a Z-Pak because they know it gets them better. Well, the point is not necessarily to not give them the Z-Pak, because sometimes I think there genuinely is a true placebo type effect. Azithromycin also has what are called pleiotropic effects, which may not be antibacterial, but they have some anti-inflammatory properties. But when you give the diagnosis of acute bronchitis and they have go into torsades, which we saw a few months ago in one of our hospitals, and a patient died, given azithromycin right there, went into Torsades, died. Those are the things that could really wind you into some trouble. So always be conscious of your diagnosis. Why are you giving that drug, and if there is a purpose to it. Common cold runny nose, of course, no antibiotics for that. Acute otitis media, it actually is, in kids, watch and wait tends to be the favorable opinions of a lot of the major organizations. Although I would say it's very tough to guarantee any sort of follow-up. So if you want to really go by the book, you see a kid today, they have acute otitis media, first incidence, write them a prescription for Friday. That way you tell mom, listen, if things are still going down, if the kid's still sick, fill that prescription, treat them on Friday. And you know what, if it's bilateral, if they've had several infections in the past, it's fair to treat them right away. Usually, I have Cefdinir up here, Omnicef, for adults. Same thing for kids. Usually what I say is start them on Augmentin. I would even say that for adults, the more and more I've read in the last year or so. And I actually updated this, but forgot to send it to Ken. You're looking to kill strep, H-flu, Moraxella, sometimes staph. Amoxicillin as a first-line agent generally is not the best choice. It only kills strep. Augmentin is amoxicillin plus clavulanic acid. That clavulanic acid will help protect from any anaerobes, from some of your gram-negatives, because really amoxicillin alone gets snipped by virtually anything that's not strep. The reason I don't say Omnicef is the best first-line agent is because it's not quite as good with strep or some of those gram-negatives as Augmentin is, based on some of the newer literature. So I think Augmentin is probably the best first-line agent, whereas Omnicef's probably your best second-line agent. But for adults, when they come in, it's reasonable to treat them off the bat, because often these infections don't clear up on their own. The other thing is when you have kids that have these for years and years and years, a lot of that comes down to their basic anatomy. They have a eustachian tube that's very flat. An adult, as we get older, it goes from flat, starts to elevate more, and that fluid that kind of gets stuck and almost forms like an abscess inside the eustachian tube will drain more in adults. For kids, that's why they get infections like that over and over again. They don't have that drainage, and that's why a major amount of the time, they're going to repeat infections and not clear infections, because it's like an abscess. And most of the time, that has to clear up on its own. It has to drain on its own, and that's the only time they're ever going to get better. Influenza, no antibiotics, of course. I do happen to think Tamiflu, it's a very innocuous drug, very little side effects. In a patient you suspect flu, if it looks like flu, smells like flu, feel free to treat them with Tamiflu. A lot of the rapid flu tests have very good sensitivities and specificities now, so if they're flu negative, it's fair not to treat them. I also think it's a reasonable empiric approach that if you have a really busy ER, your rapid flus, we were running out of them in Boardman for a while. If they have a fever, if they fit flu-like symptoms, empirically treating them with Tamiflu is not entirely unreasonable. You might hear a lot about the new drug Xofluza, which is a new one-time dose antiviral. It's not really from the community pharmacy setting. It's not available in a lot of locations. We have a limited supply in our hospitals. It's a really good drug. We've seen really good effects in super sick people, especially when you combine it with Tamiflu, but it's not widely available yet. So next year, probably September, when I'm talking about this again, I might talk about it a little more, but it's not really widely available yet for the communities. So from an ER perspective, we're not really going to use it. Acute sinusitis. Understand that in adults, 90% of this is viral. So you wind up giving Augmentin for this, and you treat 20 patients, and the Augmentin's probably about 50% sensitive for bacterial sinusitis. You have a number needed to treat of about 20. So for about every 20 people with acute sinusitis, one of them might benefit from antibiotics. That's just sheer numbers. Good epidemiological data on that. So, it's always up to you. It's tough to decipher between bacterial and viral, but understand again, a number needed to treat of 20, whereas more than 1 in 20 are going to have an adverse reaction to that drug. So it's always a cost benefit. And then sore throat, 5 to 50% of sore throats in adults are strep. Rapid strep tests, especially for kids, are very good. The sensitivities are very high, in the 90s. So when they have strep, when it shows positive, you can trust that it's positive, of course, with about 99% specificity. But when it's negative, you could trust that it's negative. With all of these upper respiratory tract infections, one of the key points to make is your worst case scenario. You don't treat one of these patients. Nobody's going to die from these. Your body clears these up on their own. Even strep throat. Strep throat's probably the worst out of all of these, where we worry about rheumatic fever and other long-term side effects as a result of it. But in reality, the vast majority wind up clearing these infections up on their own because, yes?
This is going back to the Tamiflu thing.
Yeah.
So you said you can empirically treat just on a clinical diagnosis, but what do you think about if it's over 72 hours?
If it's over 72 hours, it's probably not going to do much. Again, Tamiflu, all it's going to do is it's going to shorten your length of insult, your length of the morbidity of the disease. Yes, there is some data that in sick hospitalized patients, it could reduce your risk of pneumonia, can reduce your length of stay, things like that. But when it comes down to a person you're going to see in the ER, you're going to send home, if it's 72 hours later, I don't really expect it to do much. A lot of the data doesn't expect it to do much. It's only going to save you somewhere between 16 to 24 hours if you give it day 1 of flu-like symptoms. But it's also not going to really cause too much harm. So I would leave that up to you. Honestly, I have a young daughter. If she had the flu and was 72 hours into symptoms, I'm okay with Tamiflu, because I know that the risks versus the benefits, I might gain some benefit. I'm not really expecting any benefit from it, but I also am not really averse to that risk. And that could gain me 12 hours, which is important sometimes. But again, with most of these, if you don't do anything, I'm not suggesting that you do nothing with things that you really think are bacterial. But again, if you judge in worst case scenarios, your worst case scenarios aren't an undiagnosed necrotizing fasciitis or an undiagnosed cellulitis that could become worse. These things the body tends to clear up on their own, and the vast majority of them are viral. So explaining appropriate follow-up in 3 or 7 days if you're not getting better, again, come back to the ER, see your primary care doctor. And also understanding that a lot of these diseases take 4 weeks to really recover. You got repeat customers that come in a week later, they're not better. 2 weeks later, these things could take a long period of time. And if you read any historical literature on medicine, it took people 4, 6, 8, 12 weeks to convalesce from illnesses in the past before antibiotics. People want a quick answer now, but most infectious diseases are not quick answers, especially these. So here's your common adverse side effects. So a lot of the time we give these drugs, we think they're innocuous. Azithromycin mostly is, but people with prolonged QTCs as baseline do run the risk of cardiac abnormalities, especially your QT prolongers, potentially torsades, and things like that, may not be worth it. So it's important to assess cardiac risk when you give a drug like that. Often, in upper respiratory tract infections, I've seen a major shift to doxycycline. We know the QT prolongations with the Zithro. Doxy, seems pretty innocuous. Well, a lot of people do have GI side effects with that. Generally speaking, the drug's very well tolerated, but you do have a lot of nausea, vomiting. You could have esophagitis and ulcerations with that. Down here. Beta-lactams, we worry about nausea, vomiting, diarrhea. C. diff can happen, superinfection can happen. We have a lot of mild skin reactions sometimes. More with your general penicillins. Once you get to the cephalosporins, a lot less common, but always be aware of those. Bactrim. The big thing with Bactrim, I always tell everyone, I'll probably talk about it again later. 1, we don't dose it right. So many people dose 1 double strength Q12, which I'll talk about when we talk skin and soft tissue infections. But the other thing is older people. If people have bad kidney function, you have a person, they come in, they got a little abscess, they're 74 years old, you don't want to check a BMP. Turns out they're on something that's going to increase their potassium anyway. They take potassium salts, and then you give them Bactrim. They have poor kidney function. Well, the trimethoprim component of Bactrim in the nephron actually blocks the sodium-potassium pump. So you give old people Bactrim, they have a hyperkalemia. I see it. I mean, that's one of the most common side effects I've seen. In HIV patients, I've seen it a bunch of times because we'll give 2 double-strength tablets 3 times a day for PCP pneumonia. But in older people, you really have a very similar side effect, and it really does happen. So when in old people that you're going to give Bactrim to, 1, the drug doesn't work as well in people with poor kidney function for UTIs, which it really shouldn't be used for anyway. And 2, hyperkalemia is a major, major side effect in these patients. Clindamycin, I think clindamycin is, yes?
Also mentioned Bactrim potentiates people on warfarin, so.
It does, yes. Anybody on warfarin, major side effects. One of the things I always preface my conversations with is that most of the time it's not my ass on the line when I make these recommendations. I realize that I'm not a provider. I'm not writing the prescription, so a lot of the time it's a recommendation. But when it comes to anticoagulation, I do work at an anti-coag clinic with prescriptive authority, so with warfarin, it is my ass, and so many times somebody gives somebody Bactrim, and then I end up in a scenario where a person has a high INR, then I got to deal with it. I don't know why they were put on the Bactrim, and so yeah, major drug interactions with Bactrim, particularly with warfarin. Clindamycin, I'll talk about this at a little more length later. I think clindamycin has certain benefits, but for the most part, it has a lot of poor qualities that, especially the potentiation of C. diff, which is a little overblown, but still the most common cause of C. diff, as well as how many times you got to take it a day, and its GI side effects. And then Flagyl, obviously can't drink with it, CNS side effects, potential GI problems. So it's one that we think of sometimes as innocuous in people that don't drink alcohol, but it's not. Fluoroquinolones, any of you who go to the box site after this will see some papers I've written on fluoroquinolones. I talk about them all the time. These are awesome drugs at times when you need them, but they're becoming less and less favorable for certain reasons. 1, the FDA's put out all these statements about only use fluoroquinolones when you don't have other options. And the reason for that are all these side effects. The drug companies had been hiding these side effects for many years, and that's why you had class action lawsuits against the drug companies that really happened between like 2004, 2014. Since then, physicians, providers are getting sued because now you have all of these FDA warnings against these drugs. We all know about tendon rupture, but aortic aneurysm, hyper and hypoglycemias, and CNS side effects. This one down here, if you ever Google this and Google support groups for fluoroquinolone-associated disability, there are tens of thousands of people that basically the gist of this is that you've taken a fluoroquinolone and 30 days later, you are not the same as a result of that fluoroquinolone. Do I think the science behind this is great? Not necessarily. But when lawyers get a hold of science that may not be great, but the CDC is behind you, and there's diagnoses behind it, which involve neuromuscular, sensory, other neurological defects as a result of this, people are getting into certain scenarios of litigation as a result of this disorder right now too. And I'm telling you, you Google it, you'll see 5 different support groups for fluoroquinolone-associated disability, and people are ravenous about it. We all talk about QT prolongation. There is data to suggest oral fluoroquinolones like Levaquin and Cipro aren't more QT prolongers than penicillins, but you'll always get called by pharmacies about that. I don't worry about it too much with QT prolongation. The data doesn't back it up big time, but again, sometimes the gap between data that comes out today versus what society, lawyers, peers think about things doesn't necessarily protect you at the moment. I always briefly touch on Vancomycin Zosyn, mostly because I've written papers on it, but also because I truly see it all the time. We give Vancomycin Zosyn for any broad spectrum septic patient who has a big time infection that we're worried and want to cover them super broadly. Vancomycin Zosyn, it's a great drug combination. It's basically going to cover any non-resistant pathogens. When dosed appropriately, it's going to cover Pseudomonas, it's going to cover MRSA. But there are 32 different studies that are showing the increase in acute kidney injury as a result of this combination versus Vanco and cefepime or Vanco and meropenem. One-time doses, there's no proof that a one-time dose from an ER is going to cause any problems when it comes to this. But oftentimes you have a resident who's on, they're admitting the patient, oh, so-and-so ordered Vancomycin Zosyn, I'm just going to continue it. So many of the times what you do in the ER gets continued on admission. So Zosyn doesn't offer you much more benefit than giving cefepime. Meropenem's a little broader than Zosyn, so I don't want to say everyone give meropenem and Vanco because meropenem's a great agent in resistant gram-negatives. But those two, less kidney injury as a result. So always be cautious. Understand why you're using Zosyn. If you're treating somebody for a hospital-acquired pneumonia, they do not need Zosyn. Cefepime will do everything Zosyn will do. Vancomycin loading doses. So the Infectious Disease Society of America and a few pharmacist organizations like the Society of Infectious Disease Pharmacists, they have new MRSA guidelines, vancomycin dosing guidelines that I've seen the galleys that aren't quite out yet, but the preliminary ones, but it should be coming out later this year. And they are actually saying loading doses now in their literature are safe at 25 to 35 milligrams per kilogram, capping it at 3 grams. So their recommendation, even though they say that this is safe, they kind of downgrade it by 5 milligrams per kilogram. And this is the recommendation that's going to be coming out soon. And it's sort of what I've been preaching for the last 5 years because, again, a lot of the time the literature takes a while to catch up with practice in general. But the data has shown that loading doses are safe at doses up to 30 to 35 milligrams per kilogram. Why do we need these huge doses? Because on the inside, it helps people get to steady state quicker. Vancomycin is a shitty drug off the bat. It's awesome because it covers everything, but it takes a while to get started. It needs these loading doses to get to steady state quicker because that's how it kills better. So not to go into all the pharmacodynamics of how the drug works, but in the ER, to give people minuscule doses is doing nobody any favors. You have a 100 kg person who comes into the ER and you think, oh, I'm gonna give 1,500 milligrams per kilogram. I'm gonna give 1,500 milligrams. Little bigger dose. They're almost getting no drug. Oftentimes you're better off giving no drug in that scenario because then you mess up the person on the inside who has to dose that stuff appropriately. So all I would tell you is, no one should yell at you when you're giving doses of 20 to 30 milligrams per kilogram. And if they do, they don't know their literature. So let them know to look. When you order a dose of 3 grams for a guy who's 150 kgs, it is appropriate. I was almost going to say, I wish you would give any one of them my cell phone number so I could have a conversation with them when they try to bitch at you for it. But reality is, that's maybe not so practical, but I'll give my email address and they could politely email me. Pneumonia in general, there's not.
Kidney disease, when you give that one-time dose, it doesn't matter if the patient has kidney disease.
What's that?
For the Vanco, does it matter if the patient has kidney disease?
Great question. So the most interesting part of that is it's actually more important in kidney disease. The people I will not necessarily give big loading doses to are somebody who's young, in their 30s, got a skin and soft tissue infection, and I'm gonna have to dose them probably every 6 to 8 hours. So steady state takes about 4 to 5 half-lives to really get to where that drug's doing the job it wants. Somebody with worse kidney function, creatinine clearance of 25, that's gonna be dosed every 24 to 36 hours. You're looking at a week before that drug's gotten to steady state. So the worse their kidney function is, actually, the more important a loading dose is. Somebody younger that's churning through that drug super fast, not as important because we're gonna dose them 6 or 8 hours after that initial dose. So within a day, that drug's gonna be doing what we want it to do. But the older person, renal toxicity or renal injury to start with, well, it's more important. So yes, and it is safe in that population. Pneumonia in general, I see a lot of people, primary care doctors, patient comes in, they diagnose them with pneumonia. They're giving azithromycin monotherapy. I'm seeing doxycycline monotherapy. I mean, and oftentimes I'm actually seeing like Omnicef monotherapy. Understand, community-acquired pneumonia is pretty much half atypical pathogens. So Legionella, Mycoplasma, Chlamydophila. It's also about half what we call typical pathogens. Strep, the most common cause. H-flu, Moraxella. Omnicef, or in the hospital, ceftriaxone, Rocephin, that covers all your typicals. Your doxycyclines, your azithromycins cover only the atypicals. Levaquin covers both of them, but the point is, we're kind of a little more nervous about Levaquin nowadays. But the point is, if you're going to treat somebody for pneumonia, treat them the appropriate way. Treat them for typicals and atypicals. People are going to say, oh, it's a lobar pneumonia. Oh, it's a diffuse pneumonia. It looks like this pneumonia. None of these community-acquired pathogens have a consistent pattern on a chest x-ray. You are not going to diagnose somebody with strep pneumonia based on a chest x-ray. Yes, strep is more likely to be a lobar pneumonia. Yes, atypical pneumonias are more likely to be diffuse. But and Legionella could present in any way possible. You're not going to make that diagnosis solely based on pneumonia. Based on chest x-ray. So just treat them appropriately for both typical and atypical pathogens. HCAP, I'm not going to talk about this too much. I call it the ship without a harbor because everyone thinks that people who come from a nursing home, dialysis centers, were in the hospital 60 days ago, that these people ought to be treated with Vancomycin Zosyn, should be treated as the same as hospital-acquired pneumonia. All of the data nowadays really does not support this. We're over-treating patients. We're covering Pseudomonas when we don't need to. We're covering MRSA when we don't need to. So if a person is generally absent of certain risk factors, which I'm not going to go through this busy slide here, but if a person hasn't had recent IV antibiotics or hospital stay, or doesn't fail in this Barthel index, which shows how well they are generally, and they're not immunosuppressed, they don't need these big gun antibiotics. They could be treated for community-acquired pneumonia, even though they're coming from a nursing home. Fundamentally, think about it. They're coming from a nursing home. Does that make them less at risk for Mycoplasma pneumonia or Legionella? But you're going to give them cefepime, doesn't cover either of those. You're going to give them Vanco, doesn't cover either of those. So again, the epidemiological data for those decision makings are poor, which is why the Infectious Disease Society of America left HCAP off of its update to its hospital-acquired and ventilator-associated pneumonia guidelines. The community-acquired pneumonia guidelines haven't been updated in a decade. They're not on there either. So right now, the term HCAP, the guidelines that created it in 2005, updated their guidelines 3 years ago and didn't include that terminology again. Didn't include it at all. They said, let the community people handle it when they update their guidelines. So anybody who uses the term HCAP, it's actually a defunct word at this point, but for all intents and purposes, if they've recently been in a hospital, treat them for hospital-acquired pneumonia, but also consider adding on atypical coverage. If they haven't recently had IV antibiotics, haven't recently been in a hospital, aren't immunosuppressed, treat them like community-acquired pneumonia. Some of the admitting docs, they probably, I would tell you, 49 out of 50 do not know this because, again, it takes so long for this material to matriculate all the way through the health system. But again, you're the one who are making these decisions, not them. So, I always say practice the right way and not the way someone else wants you to practice. The most irritating part about so much of infectious disease practice comes down to the fact that most people do not know their antibiogram. So for urinary tract infections, which I think I got our UTI data here, and this is about, you see this is older data. But the point that I make with all of this is that so many people treat urinary tract infections, skin and soft tissue infections, without any idea what their bacteriology, what the bacteria that are affecting their populations are susceptible to and not susceptible to. Bactrim, I see people that get treated with Bactrim for UTIs. Bactrim is a laugh a minute. I mean, this is a drug, if you look right here, Bactrim has about 70% sensitivity to our most common pathogens. So we look right here. E. coli, Proteus, which is our number 3 pathogen, and then Pneumonia. This is at Youngstown. Boardman, really around the same. This was a different period of time where it was even worse. Oh yeah, I'm sorry. This was just in our Boardman ER. I looked at every patient who came through the Boardman ER and saw that this was actually our percentage. This was for the whole hospital. These were for the whole hospital. The point that I'm making is if you don't know your own data, which is very difficult to determine, but most hospitals at least have hospital-wide antibiograms. The point is you don't really know what you're treating. You're guessing. The Infectious Disease Society of America has 3 different 1A recommendations. Bactrim, but not if it's more than 20% resistance. Macrobid, again, not if it's more than 20%. But look at this, if it's Proteus or if it's Pneumonia, which represent about 1/3 of all UTIs in women that are postmenopausal, and a lot of men as well, Macrobid's not going to cover that. And the other one's Vancomycin, which again, it's not really the best drug for a lot of these. It has a lot of failure rates. But the point that I'm making with all of it is ask and find out what is your antibiogram, what covers what. And if the drugs you're prescribing do not cover the pathogens very well, you need to make other decisions. A lot of the time those decisions involve the beta-lactams. Ceftriaxone, which is sort of like Omnicef. That's why I recommend Omnicef a lot of the time. I see a lot more Omnicef in the community, and I do think that that's the result of our ER, both at Youngstown and Boardman, and the primary care doctors seeing that a lot of Omnicef is using. But with more Omnicef use is going to come more resistance. So we're going to need more agents, and unfortunately, actually over time, in our ER specifically, one of our best agents is actually Levaquin. So you could make the argument, well, for a person with a UTI, maybe Levaquin's an appropriate choice. But again, I'm not doing this to harp on how to appropriately treat UTIs, because the best answer with UTIs are, what does the data in your hospital say? Maybe Bactrim does cover 90% of the E. coli in your institution, which makes it a good drug. But again, understanding your patient population is important. If a person has poor kidneys, Bactrim doesn't function as well in the kidneys. Macrobid in people with creatinine clearance less than 60 isn't activated at all. Now, some of the data will say, well, we could give it in worse kidney function, but there's no good evidence to that. Also, I see people on the outside that are giving 90-year-old women in nursing homes Macrobid prophylaxis, and it blows my mind. I will see people treat pyelonephritis with Macrobid. The drug is activated in the bladder. So you got to have an infection that's in the bladder or south of the bladder for the Macrobid to work at all. So again, understanding how a drug works is important. Understanding what you're going to cover, how you're going to cover, if you're going to cover is always important. Skin and soft tissue infections. I'm just seeing a terrible trend lately of doxycycline monotherapy for diffuse cellulitis. Cellulitis is a very simple concept for 99 out of 100 patients. If pus comes out of it, think staph. If pus doesn't come out of it, if it's diffuse redness, think strep. Doxy does not cover strep of the skin great. Clinda doesn't cover strep of the skin great. Bactrim doesn't cover strep of the skin great. Beta-lactams cover it very well. So something like a Keflex is very good. An Augmentin is very good, but a little broad. Even an amoxicillin isn't the worst drug possible. I'd rather give amoxicillin for cellulitis than doxycycline. When pus comes out of it, oftentimes it's almost always Staph aureus. I see so much clindamycin that's being used right now for this. Clindamycin at Boardman and Youngstown is about 60% sensitive to Staph aureus in general, okay? In general, meaning MSSA and MRSA. So what does that mean? I'm gonna give clindamycin for this infection. Augmentin for Staph aureus in general is 0% against MRSA, but about 100% against MSSA. So it's about 40% sensitive. People think, oh, I need to cover for Staph aureus. Augmentin is almost as good as clindamycin. And this is pretty much a nationwide trend on how poor clindamycin is against MRSA. It's got a lot of side effects. It has to be taken 3 times a day. It does not cover strep well. So my comment is, unless Bactrim and Doxy have failed, and if they've failed, they probably don't have Staph aureus infection. Clindamycin, I would never recommend clindamycin to anyone. And when you see purulent discharge, abscess, and you think it could be polymicrobial, the word I love to hear, polymicrobial abscesses, or an infection that could be purulent, may not be purulent. The vast majority of the time, that area of erythema that's around your abscess is just inflammation. It's not some other organism that's around there. It's inflammation. So the data suggests with purulent patients you're going to send home, you don't necessarily need to give antibiotics. However, what I would tell you is that there's newer literature that will show that Bactrim is it's reasonable in that scenario. It's not going to cure the patient, but it's going to give you about a day to 2 quicker relief, symptom resolution. So if you're going to treat purulent infections, Bactrim is definitely the drug of choice, but it's 2 double-strength tablets every 12 hours. It's not 1 double-strength tablet every 12 hours. You don't get the levels you need to kill the bacteria. Doxycycline, still the same dose. In our institution, Bactrim's about 97% sensitive for MRSA. Doxy is a little bit better, it's actually 98%. I see more clinical failure with Doxy, anecdotally. I see a lot of clinical failure with Clinda, which is about 60% sensitive. Again, if a person has a bad sulfa allergy, they can't take Doxy, yes?
Any difference between the mono and the high flake doxycycline?
No. Just in the formulation, there is not. So when a pharmacy calls you for that, say yes, it's totally fine. But yeah, clindamycin is still appropriate, but again, it is definitely a 3rd-line agent in this scenario due to sensitivities. But again, don't take my word for it. Maybe your Clinda sensitivities at your institution are 90%. I'll tell you this, 2.5 years ago when I started at Boardman, and I looked at 6 months of their data, our Clinda sensitivities in the ER were about 85%. So I was recommending it a lot. 2 years later, it was 60%. And these things do become cyclical. It's important to look at your data, to know your data, to determine that. And then for non-purulent infections, beta-lactams. It's always my recommendation in that scenario. Sometimes you have patients that have legit allergies. I would recommend Omnicef in those scenarios, but again, if it's one where you don't want to give a beta-lactam at all, actually, Clinda is slightly appropriate. I would actually rather give Levaquin than clindamycin in a scenario like that, because Levaquin covers strep very well. And I think that it has more of a chance to help that infection versus a clindamycin. So I talked about all of this stuff. Again, your number needed to treat for better cure rates with Bactrim is about 14. So you don't necessarily need to treat, but I think it's reasonable. I always tell people, and there's no reason to get cultures if you're sending a patient home. I reviewed 188 cultures at Boardman during this time period, and that knowledge affected decision-making in 0 out of 188 cases. Diabetic foot infections, osteomyelitis. I know ID in our institution will sometimes get upset if you do one thing and give antibiotics, or if you do another thing and hold antibiotics. Per the guidelines, patients that are stable for either of these do not need antibiotics to start with. They need appropriate cultures. They need debridement and then cultures. They need a bone biopsy, and that will be cultured. Most of these patients, this disease took a long time to develop. It's going to take a long time to cure. You want the appropriate cultures so you can make the correct antimicrobial decisions for both of these. If they're sick, if they're septic, and they come into your institution sick as hell, treat them right away. Never wait on cultures to treat a patient. But if they're stable, either call ID and ask them what they want you to do, or hold antibiotics, because the appropriate decision, the one that the guidelines back, is holding antibiotics until you get those cultures. In fact, for diabetic foot, specifically says antibiotics should not be given until surgical debridement of the wound. Those little cultures surrounding the infection. I teach the residents on doing a probe to bone test, and also when we're culturing these diabetic foot wounds, you have to shove, sometimes through tissue, to get very good cultures that are useful cultures, because on the inside, the poor cultures that you might get are actually misguiding. They're worse on patient care. So don't just try to check a box with getting cultures. Either get good ones or don't get cultures. Intra-abdominal infections, I think this is right towards the end here. The knee-jerk answer is always ciproflagyl. Actually, in the Boardman ER, that might not be the worst decision, but across the country, E. coli resistance to fluoroquinolones is somewhere around 60%. What causes urinary tract infections? So medical society has become very good at not giving quinolones for UTIs, generally speaking. Why haven't they become good with intra-abdominal infections? How do people get urinary tract infections? Well, for most women, it's because the sewer is very close. All the pipes are very close to one another. So they get it from the same bugs that are in their GI tract. So that is why oftentimes Cipro or Levaquin are not the best agents for this. Give a beta-lactam like ceftriaxone plus Flagyl if you're admitting a patient. Even Zosyn monotherapy is appropriate. If you're sending them home, Omnicef and Flagyl, it's going to cover the patient far more than your Cipro and Flagyl at most institutions. And what I would also tell you is why would anybody ever give Cipro? It's stupid. Cipro's twice a day. Levaquin covers everything Cipro does, actually more than what Cipro does. Levaquin's once a day. So I would never recommend giving Cipro in any scenario because it's just nonsensical. So it's a twice daily drug, which when a patient's taking that first dose with their cereal and the calcium in the cereal binds the absorption of the Cipro anyway, they're not actually even getting the Cipro. That's why I always say, just give Levaquin if you're going to give it one of the quinolones. And also, these you don't have to treat long. The guidelines will tell you 4 to 7 days. You never need to treat any intra-abdominal infection more than 7 days. Appropriate dosing. ER, one of the major problems, always 30-minute infusions. People will give Zosyn thinking they're covering Pseudomonas, and they give 3.375 grams. This does not cover Pseudomonas. So the whole reason why you erroneously gave Zosyn anyway to cover a pneumonia you could have used cefepime for, you gave a dose that doesn't even cover the Pseudomonas you were trying to cover. Again, only 4.5 grams infused over 30 minutes covers Pseudomonas. Levaquin, there's really no reason to dose under 750 milligrams when you're dosing it. A lot of the literature, package inserts, they come from a time where gram-negative MICs were a lot lower. Today they are a lot higher. So you need higher rates of coverage by giving bigger doses. Clindamycin, whenever you do give clindamycin, it's an awesome drug in patients that have necrotizing fasciitis, really septic looking skin and soft tissue infections, Fournier's gangrene, toxic shock. It binds toxins. You're giving it for its antitoxin effects, not its antimicrobial effects. And so the dose with that is 900 milligrams. And then some of the beta-lactams. People always ask me, Rocephin, ceftriaxone. You sometimes recommend 1 gram, sometimes 2 grams. The easy answer is, when you're ever trying to cover gram negatives, for the same reason I recommend higher doses with Levaquin, because of higher MICs, I always say 2 grams of Rocephin when you're trying to cover gram negatives, so urinary tract infections, intra-abdominal infections, 1 gram when you're trying to cover gram positives or respiratory pathogens, generally speaking, community-acquired respiratory pathogens, because they're pretty stupid and they're easily killed by Rocephin. When you're trying to cover kind of both, round up. It's a generally safe drug. It's not cleared by the kidneys. 2 grams is appropriate. Oh yeah, and NSAID. People that are big, give them 3 grams. Over 120 kgs, 3 grams is always recommended. Even though this is generally what surgery guidelines will tell you, I basically say anybody over 80 kilograms, not over 80, basically anybody who's not over 120 kilograms, I recommend 2 grams. Again, safe drug, not really any harm of giving more drug. And that's the end.